Well, welcome to the Frontline Worker Pay Working Group. We have approved the minutes. We have a quorum here, so we've approved the minutes of July 28th, if you missed that. And we are moving on to a presentation from Sean Williams, nonpartisan staff from House and Senate presentation on what they are doing in other states with their millions of dollars of frontline worker bonuses. So take it away, Sean Williams.
Senator Housley and members, can I verify that everyone hears me?
We can hear you.
All right, I'm going to try and share my screen with the slides here. Okay, so to start with, we're going to walk through some of the other frontline worker programs that we identified in sort of our analysis of what other states are doing. I guess I'm going to start by saying that we know that local level programs also exist in other states implemented by some counties and municipalities, but we're not covering those in this presentation. We did, nonpartisan staff from House and Senate did reach out to the League of Cities and the Association of Counties. And as far as they were aware, there's no local programs that are currently in existence in Minnesota. Before I start, I'd also like to note that sort of the programs in these other states have been paid for using different sources of money necessarily than this committee may ultimately end up using. So there may have been different restrictions or fewer restrictions on the funding in those other state programs. So it's quite possible that something that another state did may not be allowed under the American Rescue Plan Act restrictions that Mr. Arneson discussed in last week's presentation. To start with, I just want to describe the programs that I'll be covering. So I've sort of grouped them together here into 5 categories. The first is broad programs for state employees. There's a program like that in Georgia and one in Maryland. There's programs for educators. There's 2 different ones that I'll discuss a little bit later in Florida, and then one in Georgia. There's 4 states that have implemented programs for first responders, Indiana, Florida, Michigan, and New Hampshire. And then there's 2 programs that are sort of targeted to health workers specifically in Michigan and Virginia. And then there's 3 programs I'm kind of describing as broader frontline worker programs. They don't just serve one kind of category of employee or worker. So I'll discuss in more detail later in the presentation what workers covered were allowed to participate in those programs. The first issue I'm going to discuss is program eligibility for these different programs. I sort of intentionally put quite a bit of detail into these slides. My intention is to cover this at kind of a high level, and you'll have these slides to sort of refer to as a resource in case you wanted to get a little bit more detail. And with a lot of these, you can start at one level and then start asking more specific questions and get very detailed. And so sort of at the committee's request, other nonpartisan staff and I would be happy to dive in a little bit further. So to start with, there's these 2 programs that are listed in Georgia and Maryland for state employees. Georgia provided just a one-time bonus for state employees. It applied to all state employees making $80,000 a year or less. And I'll talk a little bit later about the size of the bonuses and then also how they were administered. So I'm sort of trying to do this thematically as we go. Maryland implemented a program called Response Pay. This was sort of focused on state employees that had direct contact with the public. So individuals in the care and custody of the state, public-facing human services and public safety workers, and then certain employees that were required to work in a designated quarantine area. As far as programs for educators go, Florida actually implemented 2 different programs. There was one program that was targeted towards pre-K through 12 educators, and then a separate one that was targeted towards full-time child care, classroom teachers, and early learning teachers. So there's sort of a child care one and a pre-K through 12 one. I would note that the both of Florida's programs targeted classroom teachers only, so support staff that worked at schools didn't qualify for those programs. In comparison, Georgia did a bonus pay program for educators, and in comparison with the Florida one, the Georgia program covered faculty and staff, but also paraprofessionals, counselors, school nurses, bus drivers, other people sort of affiliated with the school. So there's a different sort of eligibility, much broader in the Georgia program. There's 4 states that I mentioned that implemented first responder programs. I provided a lot of the detail on how these states define first responder programs, and it's all a little bit different. Sort of general themes across these different programs is typically they cover EMTs, Some are all law enforcement. And then correction staff were pretty commonly covered. There's a few other kinds of individuals that were covered by these programs in certain states. So for example, Michigan had a program that covered 911 operators as well, and airport public safety officers, things like that. So there's quite a bit of variety in sort of how they define first responders. If you're interested in looking at that in more detail, I've provided that information in the slides. As far as the healthcare workers are concerned, Michigan and Virginia both implemented programs for health workers. Michigan did what they called a direct care worker wage increase. That was specifically targeted to RNs, LPNs, CNAs, and respiratory therapists who were employed by the Department of Human Services. They provided direct patient care at certain facilities defined in the statute. And in comparison, the Virginia program was targeted towards personal care aides and personal care attendants who provided personal care services to certain Medicaid members in a certain time period. Next, I'm going to discuss what I sort of have called these broader eligibility type programs. So Louisiana implemented a frontline worker rebate program. That program had an income limit of $50,000 a year. And it covered a lot of different kinds of professions. So there's health staff, nurses, nurse assistants, aides, medical residents, pharmacy staff, et cetera. It also covered support staff that worked at health facilities. So that could be housekeeping, food, laundry, those sorts of things. It also covered long-term care staff. Their program also covered some of the sort of first responders that I mentioned. So EMS, fire and rescue personnel, public health epidemiologists. I would also say there's sort of a category I might describe as infrastructure workers. So bus drivers, retail fuel center personnel, sanitation personnel, solid waste and hazard waste removal personnel, those kinds of things. It covered a grocery store, convenience store, food assistance program personnel, mortuary staff, and also veterinary staff. Pennsylvania also implemented a broad program. It covered direct full-time and part-time employees of businesses. The income limit there was $20 an hour, excluding fringe benefits and overtime. Again, they listed in sort of their program for these 6 broad areas: healthcare and social assistance, food manufacturing, food retail facilities, transit and ground transportation, passenger transportation, security services for eligible industries listed above, and commercial industries that were not closed when the governor issued a business closure order, and similarly janitorial services. And finally, Vermont implemented a program for private sector workers, sort of the broad categories. And these are my groupings. It's a very long list if you actually pull up the program guidelines, but there's kind of healthcare workers, again, social service workers, again, support services for healthcare and social service employees, such as janitorial, cleaning, and food staff, certain essential retail, so grocery stores, pharmacies. And then they had a group that they described as retailers that serve kind of basic human needs. And again, they provided more guidance on what that was specifically. They also covered childcare facilities, some security services, and then other kind of essential services, sort of infrastructure like, so trash collection, water and pollution abatement, and then also funeral establishments or crematories. Next, I'm going to discuss the amount of payment for each of these programs. This is all pretty straightforward. I would say that the most common number you're going to see here is $1,000, but there's certain ways that other states have implemented these. So Georgia gave a $1,000 bonus for state employees. Maryland, that response pay program for state employees, gave a per hour pay increase and gave a larger pay increase of $5.13 an hour if you worked in a designated quarantine area. The Florida Child Care and Early Learning program actually has 2 bonus payments. There was one of $1,000. One was paid last month, and then there's another one for individuals who are still employed coming in January 2022. They also gave $1,000 to the teachers in their program, and similarly, the Georgia program included $1,000 for educators. Some of the first responder programs were also pretty, as you can see, $1,000 in Florida, $1,600 in Indiana, $1,000 in Michigan, and that's kind of an per employee cap. I'll discuss the administration of these programs in a little bit to see how that kind of per applicant limit applies. New Hampshire also gave sort of a per week bonus for up to 8 weeks of full-time work and $150 a week for 8 weeks of part-time work. In these health worker programs, Michigan also gave a per hour increase for a certain number of months. It was beginning last July and last through September of this year. And then Virginia also gave $1,500 as their home health worker program. For these broader kind of frontline worker programs, Louisiana provided a $250 payment. Pennsylvania provided $3 an hour hazard pay for up to 10 weeks. And then there's also kind of limits at the employer level as well that are listed in the slides. Vermont also gave either $1,200 or $2,000, sort of depending on the number of hours you worked in an environment with an elevated risk of exposure to COVID. The last discussion or topic I'm going to discuss is this issue of administration. So there's a lot of ways that the states have gone about implementing these frontline worker programs, and it's obviously a policy question for the committee to determine how you all want to implement this. It's a little bit easier with the people who are employed directly by the state. So for the 2 state employee programs I mentioned, those were paid directly to state employees. For the educator programs, there's sort of 2 different approaches between Florida and Georgia. The Florida program, the employees would send to the State Department of Education, the employers would send to the State Department of Education a list of their employees that they believed qualified for this program. And then the Department of Education would mail those people checks. And in contrast, in Georgia, the State Department of Education provided funds to the school districts, and then they made payments directly to the eligible educators. There's some similar variety in how the first responder programs were administered. Florida also had employers had the similar structure for the first responder program. It was handled by a different agency. Indiana, they paid directly to their employees, kind of similar to the other state employee programs, but the Indiana program covered primarily public safety workers who were employed by the state. Michigan, they used some CARES Act money for their program, and so they actually reimbursed cities, counties, towns, and other sort of public entities retroactively for hazard pay that they had already paid in 2020. And New Hampshire, the employers actually applied directly to the Department of Homeland Security and Management, and they got money from the state that they then distributed to their employees, because that was provided sort of as a bonus pay for a certain number of weeks. In the slides that were distributed, I caught an error when I was going over them today, so I fixed it in what's in front of you right now. This slide and the ones that were distributed publicly had Louisiana, which also appears on the next slide, so you're missing the information on Virginia. In the Virginia Home Health Program, agencies applied directly to the Department of Medical Assistance, and then the Department of Medical Assistance made payments to employers so they could provide the bonus pay to their employees. And in Michigan, the employers would provide hazard pay directly to their employees, and then they'd be reimbursed by the Department of Health and Human Services in Michigan for the payments they made. As far as the broader programs are concerned, Louisiana sort of stands out here as a little bit different. So they had a program that was administered by the Department of Revenue. So workers would apply directly to the Department of Revenue for the aid, and then the Department of Revenue would verify their eligibility. They would use employment and tax data to verify that they were eligible for this program. The Pennsylvania program was another one where it was, and there's also a small mistake on this one. There was grants provided to private sector employers. So the employers would apply to the state, and then the state would give them grants to provide this bonus pay. In Vermont, similarly, is another situation or program where the employers would apply to the state, and then they would receive grants. So the last slide on here, I think that some of these policy questions are raised pretty naturally by this conversation, but I think I just kind of pull a few things out that might be interesting to the committee. Obviously, a major question is who qualifies. That means, perhaps which workers or which kinds of occupations might qualify. But also perhaps if you want to impose income limits, that's something that some of the states did and others did not. There's also a question of what period of time would be covered. I'd say that I haven't included a lot of detail on this just sort of due to time constraints, but typically these hazard pay programs were tied to work last year when perhaps the COVID risk was higher. Another question might be the amount of payment. So that's something the committee will decide probably will be tied to the amount of funding available and also the number of workers that are covered. There's a lot of different structures for distributing payments that I mentioned. So you could have an individual apply directly to an agency. You could potentially have an agency identify individuals that are eligible and make payments directly to the public. You can make direct payments to state employees. And then there's kind of, you can either do the model of providing grants to employers or have employers apply to the state, and then the state would send payments. One issue with sort of using employers as the people that are administering this or identifying their workers is if you're kind of tying this to work performed in 2020, there may be the case where certain individuals worked in a job or qualified in 2020 and are no longer employed by that employer. And so there may be administrative difficulty in kind of tracking down people that were former employees. Another question might be administrative costs. So how state agencies who are going, whichever state agencies end up participating in this program or administering it, how much is provided them for administrative costs. And lastly, I staff the tax committee for the House, so I always have to sneak in some tax information. Some of these programs included payment to employers or just to school districts, for example, to cover tax withholding. So that might be something that the legislation addresses directly or does not. And separately, kind of an interesting question that I noticed was that Florida has sort of indicated that they believe the payments they're making qualify for an exclusion from federal tax and therefore for state tax as qualified disaster relief. And so the question for the committee might be, is that some, and this obviously would be something that the Department of Revenue would choose to weigh in on, whether or not they sort of similarly agree that these payments could qualify as disaster relief, because the committee might get more money out to workers if that sort of exclusion from tax may apply. And, so I think it may depend also on who's getting paid and under what circumstances, whether or not that exclusion would apply, but it's something for the committee to keep in mind. So that's the end of the presentation. I'm happy to stay on for any questions from members.
Thank you very much, Mr. Miller. I do have two questions. Did these other states have the same amount of money that we have, $250 million, and where did they get their funding from? Did they just use what they were allocated from the federal government?
Chair Housley, I think it varied from state to state. I would say as on the whole, they typically had less money, but some of these programs, I think that some of the broader programs may have been a little bit bigger. It's kind of hard to do an apples to apples comparison just because the states have different populations. And so $250 million might mean something different in Minnesota than it would mean potentially in New Hampshire, for example. I'd say generally that the programs, when I was looking at the total cost, they cost less. It's also hard because in some cases there was an initial allotment of money and then it was extended or re-upped or kind of added to. And so it was, I sort of held off on going into that because I didn't have enough time to sort of dig into each of these programs to make sure they had not been extended. With regards to funding sources, I think it's a lot of the programs, I'd say the two sort of main common sources that I noticed were CARES Act money. So probably not applicable in this case in Minnesota, and then also the American Rescue Plan Act funds. And I think that particularly Florida, for example, use those American Rescue Plan Act funds. And they actually heard from the Department of Treasury that potentially their payments to education workers may run afoul of some of the American Rescue Plan Act regulations. So I know that's been an issue in Florida as well.
Thank you, Mr. Williams. Members, do you have any questions or anybody on Zoom? Oh, Representative Winkler.
Thank you, Madam Chair. Mr. Williams, do you have information about whether employer participation was mandatory? So I noticed in a number of these programs, the employers had to either pay and get reimbursed or submit information to the agency to get, so the agency could make direct payments. Do you know how they handled that so that we make, if we ended up looking at a model like that, how we can ensure that all the eligible employees are actually having their employers participate?
Mr. Williams.
Chair Housley and Representative Winkler, I don't have that off the top of my head. My initial impression, just from researching these application processes and the guidelines in the different states, is that in most cases it was voluntary programs, but I think I probably want to just look into that a little bit more detail and make sure I got those details right and I didn't miss something. But my impression was that it was voluntary in most cases for the programs that were grants to employers.
Thank you. Senator Murphy.
Thank you, Madam Chair. And this is potentially a question for Mr. Williams or for the committee as we move forward. But Mr. Williams, you mentioned that different states have used different sources of money, including the American Rescue Act and CARE Act funds. And I am wondering if there'll be an accounting or if we'll get guidance about how those funds may have been used in Minnesota prior to this piece of legislation allocating $250 million. It'd be helpful to know where we've already been as we're going forward.
Thank you, Senator Murphy. Mr. Williams, do you have anything to that?
Chair Housley and Senator Murphy, I don't have that information immediately available. I think that we could certainly work with the fiscal staff that are staffing the commission to come up with some of that information for you. Yeah, I think we can provide that. It gets a little bit tricky because there's sort of funds that may be spent directly out of the ARPA pot of money. And then there's a separate kind of amount of money that was transferred to the general fund effectively as part of this revenue replacement. And so we may want to iterate that, kind of break those two categories out and see if to what extent that money has been spent. But I think we'd be happy to follow up with you on that.
Thank you. Good. Oh, Representative Winkler.
Thank you, Madam Chair. I do have one follow-up. Mr. Williams, I take it that there are no other states currently with programs pending or with similar, that hasn't been rolled out yet. And if there are others who are kind of going down this path still, it'd be interesting to hear more about that. And I think in the future, it would be helpful to have at least raw dollar totals for what these other programs have cost. We can match that against state budgets or state populations, but just to get sort of a sense of where we stand versus other states and how much of a trail we are blazing with our work in this working group.
Thank you, Representative Winkler. I was going to say the same thing. If there's any new updates from other states, if Mr. Williams, you could come and give us those updates as they happen.
Senator Housley and Representative Winkler, we'll keep an eye out for other programs out there, and we're happy to provide some of that information about costs.
Awesome, thank you. All right, up next, we have an overview of long-term care settings, what was going on in our assisted living and nursing homes. First up, we have Nicole Matson, Vice President of Strategic Initiatives, Care Providers of Minnesota. And after that, you can be on deck, Erin Hilligan. So thank you for joining us, Ms. Matson.
Good afternoon, Madam Chair and members. I am Nicole Matson with Care Providers of Minnesota, here today with the long-term care imperative. Our members, who consist of providers throughout the senior care continuum who provide care and services to older adults statewide, have served heroically throughout the pandemic. Their work has supported Minnesota's most vulnerable nonstop, 24/7 for the last 508 days of this pandemic. The long-term care imperative's hero pay proposal, which was Senate File 2313 and House File 2221, was intended to both honor their work and thank them for the contributions they made to the health and well-being of Minnesota's seniors during the pandemic. Far too often, workers in senior care are undervalued and underappreciated. But the men and women of the senior care workforce play a vital role in the care continuum for older adults. Their work ensures that seniors can access care and supports when they need them and where they want them. We also saw this bonus as a means for worker retention at a time when we're facing critical workforce shortages, to let long-term care workers know that they're seen, that their sacrifices are recognized, and that their contributions matter. These are workers who continue to do good work because their residents and patients needed them despite the risks, known and unknown, particularly in the beginning, which I know our other testifiers will speak to. When they were not prioritized for PPE, there was no testing, no vaccines, lots of fear, incredible shortages of workers, and really no other tools other than determination and grit. They all still showed up. Early in the pandemic, long-term care settings were decimated by rampant asymptomatic spread and shouldered a disproportionate share of COVID cases and deaths. Long-term care workers worked tirelessly to adapt to new infection control, visitation restrictions, and other protocols to mitigate viral spread in their facilities. Then, as testing became more prolific, cycles of worker quarantine arose, and many settings experienced acute staffing crises. The resiliency and fortitude of the long-term care workforce was evident as they managed to respond to these challenges and continue to prioritize their residents' needs. To give you a little bit of context, as you reflect on bonus pay, consider these factors about our workforce. The senior care workforce is comprised of 80,000 staff serving over 87,000 seniors in nursing facilities, assisted living, and other congregate living situations. Our workforce is predominantly women, and 25% of our workforce are people of color. In fact, proportionately, our sector is the most diverse in the state. Statewide hourly median pay rates in our sector range from $16.42 for a nursing assistant, $23.67 per hour for a licensed practical nurse, to $31.17 per hour for a registered nurse. High rates of turnover are problematic in our very people-dependent profession, and even prior to COVID, we had high levels of turnover, which were amplified by many aspects of the pandemic. Many of our members are experiencing turnover rates as high as 70%, and at any given time, we have approximately 10,000 unfilled caregiver positions. This is occurring while demand for service and supports continues to grow. We estimate that we will need 25,000 more caregivers to meet future care and service needs of our aging population in the coming decade. This is a workforce who is on the front lines of the COVID response and will continue to show up for Minnesota seniors as our state faces yet another pandemic wave. These are the heroes of the pandemic. It's been stated that whatever the working group proposes is likely not enough, and while that's true, a meaningful bonus is a start. It's a tangible recognition of long-term care workers' service and commitment throughout this extraordinary public health emergency. And I know that our testifiers can articulate the sacrifices much more clearly than I can, so I'll turn it over to them.
Thank you, Ms. Mattson. Erin Hilligan is up next with Ebenezer, and then Sarah Blair from Sauer Healthcare, you're on deck. Welcome to the committee, Ms. Hilligan.
Hi, Madam Chair and the committee. Can you hear me okay?
Yes, we can.
Welcome, and I'm glad to be here. I'm a little bit nervous, I'll say that, because I've been waiting for a chance to share the story of something that's felt so heavy for 18 months.
Oh, Ms. Hilligan, can you say your name for the tape?
Sure.
Thank you.
Hi, I'm Erin Hilligan.
Thank
I'm
you.
Vice President of Operations at Ebenezer. Can you hear me now?
Yes, and don't be nervous. You're
I'm
great.
a little nervous. And that's because the weight of this hearing and talking about our caregivers is so close to my heart. So I want to do it justice with some stories and some examples. I'm humbled to share with you the experiences that we've had over the last 18 months. At Ebenezer, I represent over 3,700 employees, caregivers, that have shown up to work since we shut down what I call St. Patrick's Day of 2020. The rest of the state of Minnesota shut down, but we did not. Our doors shut, but we showed up to work. When we shut down our doors, we weren't sure what was going to happen next. All of our essential workers came in, and it was all hands on deck. We had no idea what was going to happen. We could see the virus making its way across the nation. We knew it was coming to Minnesota. We literally were holding our breath every day. Did we have a case? Were we going to have a case? What was going to happen? We didn't know. We were wondering. We could probably hold on for 2 to 4 weeks like this. It's 18 months later, and we're still doing it. How are we going to do this? It affected everybody. Housekeeping. Did we have the right supplies? Were they going to be able to kill the virus? You know what? We had some that didn't. We had to throw them out. Did we have enough PPE? We actually didn't. We figured out how to reuse gowns. The hospitals had them, but we didn't. I remember a nurse sending me a picture. She literally took a garbage bag with some arm things, and she sewed it together in the back of her yard to say, I think we can make some of these if we need them. Garbage bags for our frail seniors. But that's what we had. I wasn't sure. N95s. Everyone was talking about N95s. We didn't have them. We weren't fit tested. We didn't have access to them. We were hoping for a regular surgical mask. Many of my colleagues I know, not in my organization, but used cloth masks because they didn't even have access to these. Everybody was impacted. Maintenance. We never talked about HVAC as much as we did with that kind of thing. How was the virus moving around? Culinary. How do we serve all these residents in their rooms or in places that they can't go? The front desk. all of a sudden became a security guard of who could come in and who couldn't, and how do we have to help them. Chaplains, education, nursing, all the departments were different. I remember when I got a call of our first resident positive, we were all scared. What was gonna happen? What was gonna happen to the residents? What if we didn't have enough caregivers? Do we have enough pairs of hands? What should we do? What kind of testing? Nobody knew. But we just sat there and figured it out. We had way more questions than answers. But we rallied around the PPE. We figured out how to store. We figured out how to share. We figured out how to reuse things. Even though we didn't know it was enough, we figured out how to do it together. People worked double shifts, as many shifts as they needed to, and everybody's hands on deck. Everybody helped with garbage. Everybody helped with supplies. Everybody helped deliver. Everybody helped, because we didn't know how many pairs of hands we were gonna have. I remember the first time we had a COVID positive resident in our memory care in one of our communities. And if you don't know this, the virus is deadly. And we didn't know, there was nothing we could do. I remember the staff reaching out to me and saying, what do we do, Erin? And I said, we just have to pray. And I said, do what we always do. And they did. That's exactly what they did. They came to the resident, they came to the family. We did a dignity walk. That resident passed away. They cried, I cried, we all cried. It was our first death. And all we could do was watch the virus. And the staff showed up the next day. They showed up, and they show up, and they show up. In an industry, we had to pivot quicker than I've ever imagined in my 25 years of being in senior living. Everything's different. We were running communities, places where people to live, and now we were focused on safety and security for the quality of our residents. The number of pivots I can't even explain. Shutting down dining, shutting down the front door, figuring out how to get our work done with 50% less pairs of hands. How do we get things done? We didn't have volunteers. We couldn't use our chaplains. No art, no volunteers, no engagement for our residents. Yet the caregivers in every department showed up every day. Before there were vaccines, we were asked to stand up, a special TCU to help residents that were in the hospital that were COVID positive. Staff members raised their hands and said, I will do it. I will do it. We didn't have everything. We had the best supplies possible, and they did it. Strangely enough, I had a family member stop me last week, and she said, she didn't know what I did. And I said, oh, I work for Ebenezer. And she said, oh my gosh, my grandma was at Ebenezer during COVID. And I said, really? And she said, yep, she went there because she got COVID in her building and had to go to the hospital and had to go to a place. And I said, wonderful. And she told me where it was. And she said, my grandma got the best care and came out of there stronger than when she started. We did that with caregivers that raised their hands. They said, I will do it because I can. The virus has been hard, and it's been hard to battle. But I want to leave with the thought of hope. It's the caregivers, it's all of them that continue to follow their calling and show up. They show up every day. We lost about 12% of our workforce because of COVID, but the other 88% are showing up. They figure out how to do activities in hallways to maintain engagement of residents. They figured out how to stay connected to residents when we were no longer a community. Our mission's never been stronger. It's the people that matter. When I say 3,700 team members, that's 3,700 people that are showing up every single day to make a difference. They're all Minnesotans, and they all care. Today, as I sit here, we're back to eye protection, increased testing, masking, and they show up. We're in our fourth wave of COVID. And it's because they care about the residents and they care about the team in which they work for. I feel like this hero pay is a very public honor to them to say we as Minnesotans are standing up and saying, you long-term caregivers deserve this. You have weathered a terrible storm and we're not out of it yet. Maya Angelou is one of my favorite poets, and I think about her as I was writing this today and thinking about what do I come up with. And it's something like, people won't remember what you said, but they'll remember how you feel. And so I've been out kind of doing my own tour of positivity and talking with caregivers. And they tell me the same story all the time. It's been terrible, Erin. This has been really hard. But they always leave me with the sense of hope. Like, I wouldn't want to do it anywhere else. Thank you for supporting us. Thanks for showing up. I wish somebody would recognize how hard this has been for us. We feel like we've been left out. So as the rest of the world is kind of opening up, we're back to masks, eye protection, increased testing, and a lot of oversight to make sure that we're following infection control practices. I would want my mom or dad or grandma or any friend to be cared by any of our caregivers in any of our communities. And I suspect the other folks that are coming behind me will say the same thing. These are true heroes that are showing up every day and with not knowing what they're going to step into. So I ask you, I implore you to think about, as we're looking at this pay, the hero pay, to really honor those that are working in long-term care because they deserve it. And it's been a long 18 months and we're not out of it yet. This was a public acknowledgement of what they deserve. Thank you.
Thank you so much, Ms. Hilligan, for your testimony, which was very good, thank you, and for what you do for the people you care for. Next up, we have Sarah Blair from Sauer Healthcare. Welcome to the committee, Ms. Blair. Please state your name for the tape.
Thank you, Madam Chair and members of the working group. My name is Sarah Blair. I'm the administrator for Sauer Healthcare in Winona. We are a small, private, nonprofit facility, skilled nursing facility with about 100 staff and currently 40 residents. I personally have worked in long-term care since 1997 as a social worker for 14 years and the last 10 as administrator at Sauer Healthcare. Thank you for this opportunity to speak to you today and share our experience of what it has been like to be among the first on the front lines of this pandemic. March 24th, 2020, Sauer Healthcare was the 4th facility in the state of Minnesota to have a COVID-19 positive case, and we had the first case in our county. At that time, as a country, we still knew very little about this virus, how to keep it from spreading, and what treatments were effective against the virus. We paid close attention to headlines reporting the virus rampantly killing thousands of people globally, and right here in Minnesota, there were preparations being made to care for the expected sick and dying. Needless to say, we were extremely frightened. Testing was limited and difficult to come by. For each test, I personally had to contact the local hospital to talk with a member of their leadership team to determine if they had adequate supplies to test another symptomatic staff or resident. Over 5 weeks, 44 residents tested positive and 26 staff. Those numbers do not include staff that weren't able to work due to high-risk exposure quarantines. Although the Winona community rallied and provided unwavering support, as a team we felt devastated that we could not stop the spread despite our best efforts. The emotional toll of coming to work each day to learn another resident had symptoms or another team member was sick was heart-wrenching. Our ability to comfort each other and the residents was impeded by social distancing and bulky PPE. Every single day, our nurses called each and every family member of all of our ill residents to provide updates on how their loved one was doing. For 44 residents and families, our staff had to have the difficult conversation of what if, as we helplessly cared for them. We sat with residents who were dying while relaying messages from their loved ones who watched powerlessly outside the windows. Overall, we had 15 residents die from COVID-19 during our outbreak in March and April. And in all this uncertainty and sadness, we never gave up. Our staff never stopped caring for our residents, and we never stopped fighting for them. While the state took measures to reduce barriers to employment, such as temporarily accepting out-of-state licenses, we've lost almost a year's worth of CNAs as those campuses offering classes shut down. We saw a broad swath of our experienced healthcare workers decide to retire prematurely. We saw our frontline workers elect to take jobs paying nearly the same rates in other non-healthcare settings. All this while a large portion of our community enjoyed extra time at home with friends and family receiving weekly unemployment stimulus. Our workers showed up every day, day after day, to a high-stress, high-demand environment, prepping for shift ahead in PPE and getting up to speed on new guidance since their last shift. After we conquered the outbreak, we were worn out. We all needed time to process and recuperate. We still do, but there is no workforce to fill in. Healthcare openings are in high supply. Every facility is stretched, and with a new wave of variants looming on our doorstep, what our employees need now is acknowledgement, both for what they've already stepped up and did, but also because they have stayed and committed to caring for those who are most vulnerable. I thank you for taking the opportunity, giving me the opportunity to come speak with you today and prioritizing our long-term care and essential worker bonuses. I'm happy to answer any questions.
Thank you so much, Ms. Blair. And thank you, too, for what you do. We have Amanda Gruber's next, but she's online and she's not there yet, so maybe she's coming on and they'll let me know. We've got Zinnia Harut from Affinity Residential Care. Maybe we don't? Oh, come on up. Sorry, the online person isn't here, so you're up next. Thank you so much for coming. And if you could say your name for the tape when you finally get to sit down. Sorry to
This one right
surprise you.
here?
Yes,
Okay.
that's great. Yeah, just say your name for the tape. Thank you and welcome.
Good afternoon, everybody. I'm Zania Harut, and I'm the Director of Nursing at Affinity Residential Care in the Twin Cities. Affinity Residential Care is a residential assisted living provider, and we have 4 locations in the Twin Cities. We specialize in mental health. Sorry, I'm a little nervous too.
No, you're doing good. Can you pull the microphone a little bit closer? Thank you so
Like
much.
right here? Okay.
You're doing great.
All right. In early 2020, one of our staff members fell sick with a mysterious respiratory condition. Shortly after, the residents in our home with the most complex medical conditions became severely ill. We all feared the worst. We were all hearing in the news and on the radio about how so many people were dying of COVID. Due to staff shortages, myself and another nurse transported the residents to a nearby hospital and received the worst news ever. All but one resident was tested positive for COVID. I could say that all of our staff left at that point. The text started flooding in. I'm so sorry, Nia. I love these residents and I love you, but I have to protect my family and myself. Many of our frontline staff are also caregivers of elderly parents or immunocompromised family members. I understood wholeheartedly, and I took no offense to those who could not risk it. As healthcare workers, we have indents in our faces due to prolonged mask use that we know will go away after some time. But unlike the indents in our faces, the losses we've experienced during this pandemic are everlasting. We man technology to hold virtual birthdays, holidays, and sometimes goodbyes. We did whatever we could to keep things together for our residents. My 7-year-old daughter has an underlying heart condition, and due to the highly contagious nature of COVID-19, I made the decision to send her to my parents' home 2 hours away. The sacrifices we make extend way beyond ourselves. I couldn't hug my daughter for almost 2 months. I know my story is not unique, but I want to express how many of us have been pushed ultimately beyond our physical and emotional limits. There was so much unknown. We were so scared. Honestly, we're still scared. We're scared that as the cases continue to rise, it will bring us over the threshold and that things will get back to where we were. Even though I feel more confident now and more prepared because of what I've experienced, I don't want to go through that again. Similarly to how all of us have adapted to breathing through masks for extended periods of time, our residents had to adapt to us being their closest family and support for extended periods of time. While we don't want to go back to those times, we are grateful for the support of our workforce. I want to thank my fellow healthcare workers for being resilient when our residents needed us the most. Without providers like us, care for the seniors and disabled would have suffered immensely. We are the glue that kept the entire system together. I ask that you prioritize our workforce when considering bonus pay for all of us. Thank you.
Thank you so much, Ms. Harut. That was, again, thank you for what you do and what you did through this pandemic. Next up, we have Austin Billy from Northridge Health and Rehab, and then Kari Thurlow's on deck. Thank you so much. Mr. Billy, please say your name for the tape.
Yes, good afternoon, Mr. Chair, Ms. Vice Chair, Madam Chair, and members of the working group. My name is Austin Bliley. I'm the Regional Vice President with Mission Health Communities, which is based out of our New Hope, Minnesota location. Northridge Health and Rehab is the largest skilled nursing home in the state of Minnesota. We provide or have under our payroll at the skilled nursing home over 400 dedicated, experienced skilled nursing professionals. We also have a larger assisted living on our campus as well that employs over 100 caregivers. I think I can speak for the long-term care workers, but our lives were forever changed by the pandemic. While some industries were successful by working remotely, our residents needed continued in-person care. Our model never wavered. Staff showed up to take care of our residents, no matter what the threat was of the unknown. As I reflect on the past 18 months, at the very start of the pandemic, my initial thoughts go immediately to our residents and our long-term care workers, our healthcare staff. Most of those employees did step up. They showed up to the plate to take care of our residents and attempt to keep the families informed of the constant changes, really, as we began to see the cases rise in the state of Minnesota. Our long-term care staff set aside their fear of contracting the virus to do what's right, take care of our frail, clinically complex residents. Our long-term care staff are truly heroes, showing up when many others found themselves with jobs at home or utilizing some form of assistance to stay at home with families. Our staff showed up. Many of us had to sacrifice our personal lives while juggling the many resident and regulatory priorities of the pandemic. Work-life balance was never more challenged for our staff. Their roles, our roles, as mothers, fathers, daughters, sons, sisters, brothers, it still remained a priority, but certainly added a level of stress as we continued to sustain one of the most high-profile healthcare environments, all the while with added scrutiny from the federal government to the local media. Also, as they were dealing with additional stressors such as a child living at home, a spouse who may have lost their job, or caring for that family member who needed extra help, then certainly was at home, not only inside our care communities, but at our home. And you can imagine that additional layer of stress. Despite it all, long-term care workers showed up to take care of their residents. In the beginning of the pandemic, there was so much fear of the unknown, the lack of PPE, the lack of any type of federal or state guidance for our long-term care settings, and quite honestly, our most valuable resource, our staff, were scared. But with that being said, long-term care has traditionally faced ongoing staffing challenges. So during the pandemic, this was heightened. Staff were scared. So that meant a lot of the employees had spent the past 18 months picking up extra shifts, doing what they needed to care for our residents. Being physically present at work meant their families at home, their own personal health was at risk. And of course, this risk continues on today. The pandemic wears on. I believe it is the utmost importance to recognize this special work led by our long-term care staff. During the course of the pandemic, it was extremely heartbreaking to see several of our residents' health deteriorate rapidly as COVID took their body. Due to our visitation restrictions, many of these residents didn't have a family member or loved one beside them during their final moments. But as healthcare workers, as long-term care staff workers, we did everything we could to fill that void. We had staff that would sit at the resident's side while on the phone or on a video call with their family. That long-term care nurse, nursing assistant, activities, social work assistant, housekeeping, maintenance, anybody that was available. They became a critical lifeline for our residents as surrogate family members. The residents were scared, our staff were scared, families were scared, but we as a profession showed up to take care of our residents. While things have certainly gotten much better since the vaccine has become widely available, our healthcare staff continues to wear layers upon layers of PPE every shift they come in. We continue to follow strict testing guidelines and continue to feel the daily stress that the pandemic has created in its long and lasting wake. The experiences and memories that long-term care staff have from these past 18 months will definitely stick with all of us for the rest of our lives. These kind, hardworking, undaunted men and women are truly heroes. They are brave, they are courageous, and in the face of the unknown, sacrificing their own lives, their families' lives for the safety and comfort of our residents, they showed up. They showed up to care for the residents. I believe that caring for seniors is a calling. I appreciate the work of this work committee. Recognizing the work of our long-term care employees is critical to the future of senior care. It is imperative that the profession be supported by all of us. Thank you for giving me this opportunity to speak today. By providing meaningful bonuses to the workers in the senior living profession, you continue to support many seniors in need of professional care provided by exceptional professionals, our heroes. Thank you.
Thank you so much, Mr. Billy. It's true when you think about it, that it is critical to the future of the care of seniors, how our long-term care workers are treated and they were truly heroes through the last 18 months. I can't even, I hate hearing the stories, but we need to hear them because it was hell for all of you guys, and you did a great job. Thank you.
Thank you.
Ms. Thurlow from LeadingAge. Please state your name for the tape, and welcome to the committee.
Good afternoon, Madam Chair, members of the working group. For the record, my name is Kari Thurlow. I'm the Senior Vice President of Advocacy at LeadingAge Minnesota, also here on behalf of the Long-Term Care Imperative. I think I've worked with almost every one of you on different issues related to Minnesota seniors for the past 15 years. This might be the most important issue we've ever talked about. So over the last week and today, you've heard from a variety of people who work in Minnesota's assisted living and nursing home settings, and they can tell their story way better than I can. For my testimony, I'm going to try to do three things. I'm going to try to pull out a couple of themes that I know you've heard over and over again, but they bear emphasis in this discussion. I'll then talk about a little bit about the unique role that you all play in the ability to influence wages and benefits for this set of employees, because I think that's relevant to this conversation. And then last, we'll talk a little bit about the data and what we hopefully can provide some helpful information about potential fiscal impacts as you consider some of the decisions before you today. So first, about a couple of themes that bear some emphasis here. The first is that for the past 18 months, I think it's especially evident now that this has been an all-hands-on-deck situation. At the height of the pandemic, it was not uncommon for providers to have up to half of their staff quarantined on any given day. And there was no temporary staff available. Caregivers did what they needed to do to meet the needs of their residents. They didn't have the option to limit their hours of operation or the services they provide. In addition, when these settings closed to visitors, those that worked in long-term care took on the enhanced role as surrogate family and friends, facilitating Zoom calls and window visits, while also meeting the healthcare needs of those that they served. They comforted the residents who are their neighbors, their friends, and sometimes their own family. They experienced the loss of residents and in some instances their own caregivers or their own coworkers. And this has taken a toll on them emotionally. The second theme that I'd like to point out is that this pandemic is happening during the worst staffing crisis we have ever seen in our sector. Like many other sectors, people left our field in droves during the pandemic, and we have not fully recovered. I know you have a handout in your packet, and I know Ms. Mattson testified earlier, but it bears repeating. Today, we estimate that on any given day, we have over 10,000 open positions in our field of long-term care. That means that almost everybody is working short-staffed. And when you consider that we will also need to still add an approximately 25,000 additional caregivers to meet the growing demographics, it is truly frightening, the workforce crisis that we have today. Simply put, staff are mentally and physically exhausted. And yet at the same time, they're gearing up for the fourth wave, driven largely by the spread of the Delta variant. And yes, we have more tools than we've ever had before. We know more about the virus. We have better supplies of PPE. We have vaccines, and we're doing our best. But working through this sustained crisis is taking a toll on those that have stayed. So the long-term care imperative has advocated since early 2021 that the work of long-term care deserves to be honored and elevated. A meaningful bonus would be a step in the right direction. And at this point, I need to recognize and thank Senator Housley as well as Representative Erin Hilligan for introducing Senate File 2313 and House File 2221 during the legislative session that provided some roadmap of an idea of how we could go about doing this. We also want to thank legislative leaders for recognizing the importance of long-term care by explicitly mentioning it in this group's charge as well. As policymakers, you have a unique role in financing long-term care and influencing the wages that are paid to these caregivers. You control the levers, especially in nursing homes. You set the rates for Medicaid, and because of Minnesota's rate equalization law, that is also the rates charged to privately paying individuals. Under our current reimbursement system, if a provider wanted to provide a bonus or even a wage enhancement, they would have to cash flow that for 21 months, meaning it would take 21 months before those costs are recognized in rates. And at a time when there are added costs of PPE and testing and also census decline during this time, there's little cash available to make this happen without your help. A one-time bonus will not solve all of the workforce issues in long-term care, but it is a step in the right direction. It provides you a unique opportunity to acknowledge the meaningful contributions these caregivers have made to the state. Recognition matters, especially at a time when we are looking to recruit more than 25,000 additional caregivers to the field. So in the last hearing, you all challenged us to bring forward data to help you get your arms around what this would cost. You have a great task in front of you with over $250 million to spend, and that's a lot of money, but acknowledging that there is a huge pool of essential workers even beyond long-term care. I would say that the fiscal note varies greatly on the decisions that you make about, as nonpartisan staff covered earlier today, about who you include and how you determine what is eligible, whether there's an hourly basis given, whether you require them to still be employed in those settings. So Senator Housley's proposal that we, on the back of the envelope, estimated, which had some parameters, it provided a $700 bonus and parameters for requiring hours worked during 2020 as well as still currently being employed, was around $29 million is what we estimated. Now, we're not sure that some of those parameters still make sense since it is many, many months later since we first introduced that. But to kind of give you a contrast, another point of discussion from this work group from last week is if we tried to benchmark a typical 2-week pay for somebody who might be quarantined. That would be approximately $1,500 for full-time employees in our sector and prorated then for part-time. And we estimate that that would be, again, without any other eligibility criteria, so I'm trying to give all the appropriate disclaimers here, approximately $96 million. That would cover 38,000 nursing home employees and 41,500 assisted living employees. And again, you know, if the work group in its decision-making would like us to refine those estimates, we are happy to do so. Again, those are based on the median wages that we've supplied to you in your handout in your packet as well. Of course, depending on your decisions regarding the bonus amount itself, the fiscal note is also adjusted proportionately. So that just gives you a sense of a starting point as well. I want to thank you for your time and attention today, and I'm happy to answer any questions that you might have. Thank you.
Thank you, Ms. Thurlow. I do have a question. Was that $98 million for the 38,000 nursing home employees and 41,000 assisted living? Was that at the $700 bonus?
The $96 million fiscal note that we estimate would provide a $1,500 bonus for full-time employees in all full-time employees in nursing home and assisted living. And we assume that bonus is prorated for part-time employees in those settings as well.
Thank you, Ms. Thurlow. And that, you said all employees, that would include the nurses, the caregivers, the cleaning staff, the cooks, everybody employed.
That's correct, Madam Chair. We strongly believe that that should be a principle of this bonus because it was an all, and continues to be, an all-hands-on-deck situation.
Thank you, Ms. Thurlow. Questions from any members? I don't see any online. I know I had another one. I may call you back up, Ms. Thurlow. Thank you.
Of course, Madam Chair. Thank you.
Thank you. So next up, we're going to have in person Veronica Fanubo. from the Villa at Osseo. I think she's here in person.
I'm online.
Oh, she's on Zoom. Veronica, are you on Zoom?
Yes.
Oh, there you are. Hi, Veronica. Welcome to the
Hi.
committee. Say your name for the tape, and then you can go ahead.
Hello, members and commission. My name is Veronica Funibor. I live in Elk River. I am a union of the USCSW Local 633. I work at the Villa at Osseo as an LPN, taking care of some of the most vulnerable among us. I am here today to voice my support to the working group in favor of providing frontline workers pay for essential workers. I live in Minnesota with my family. Before then, I lived in Ghana. I have an auntie in Minnesota too, and she was a nurse at a long-term care center. I started working in the healthcare over 2 years after I got licensed as an LPN. Before COVID hit, my days taking care of residents at work were normal days, going to work for a regular shift and coming home to my family. Everything seems fine. After COVID, everything changed. First, I noticed staff not showing up to work because of their family having some underlying diseases, and some are high risk. Short staffing made us work double or triple shift for 3 or 4 days at a time. There were extremely long days. Sometimes I could work 5 days in a row from 6:30 to 11 p.m. I had to find someone to release me from work. I have someone to release me from my shift before I could leave at 11 at night. And sometimes I stay until 1 a.m. in the morning. I was exhausted, frustrated, and scared. I saw my coworker not showing up for shift, but I held on. I held on for myself, my family, and my residents. My household got sick with COVID. My husband, my son, my nephew got sick. I had to sleep in the basement many days and talk to my family on the phone. Because of my family and the residents, it was crazy. At some point, because we were so short-staffed, we were working with COVID patients and non-COVID patients on the same shift. This means we were finished with COVID patients, and we will take off our gears and clean up and get dressed in clean gear to go to care for a non-COVID patient. Contamination happened. I did not stop thinking about the risks of myself, my family, and the residents after I left work. Going to the grocery store was bad too. Even though I could be clean and always wear masks, I was afraid I was going to spread the virus to others. I thought I am putting people at risk. That is not fair. When I take cash out of my pocket to give to the cashier, I thought, am I spreading the virus? I joined the USCW in 2020 when the pandemic was already on the way. Our employees voluntarily recognized our units. This helped us raise our wages and have workplace protection in rating. I know that many of my colleagues who work in the healthcare do not have union yet. I see the incredible toll this took on them, especially during COVID. I know this because I have colleagues that work in other long-term care homes. We must do better for the healthcare workers to raise wages and protect workers. All frontline workers deserve additional frontline worker pay in Minnesota. We are still putting our lives on the line. We deserve something better. Thank you for your time.
Thank you so much, Veronica, for taking time out of your workday to meet with us. And thank you for what you did and are still doing, and the sacrifices that you made and your family made. You too are a hero, so thank you. Next up, we're going to go to Joanne Snyder. I think you're here in person. Joanne is here in person, and then we will have Sabrina Collins, who may be on Zoom yet or maybe not, but we'll see if she comes. Thank you for joining the committee, Ms. Snyder. Just state your name
for
for the
having me.
record. Welcome.
Good afternoon. Hello, Chair and members of the community. My name is Joanne Snyder. I have been a cook at the Estate Freely Nursing Home for 22 years and a member of the SCIU. I love interacting with our residents. Our daily challenge is making sure residents are happy with their foods and following their diets so they can be happy, which is not this is not, to most residents, it's okay, but a lot of them, they're really picky.
Yeah.
It's not as easy as people like to think it is. Our job is not one of we're able to do from home behind a computer. During COVID, I've missed going out and talking to our residents in the dining room because now they're in their rooms. COVID has been really hard because we have short-staffed, not just on the floors, but also in the kitchen. People had to miss work of COVID, and that made it so hard because we, even in the kitchen, had worked double shifts or work by ourselves, cook and do dishes. Not fun. I'm lucky I haven't caught COVID, but many of our teams did. And it was scary for all of us. I was scared to bring it home to my mom. I appreciate you all focusing on nursing home workers today, but I do hope that you don't forget the people that are behind the scenes, like us, the cooks, the laundry workers, the cleaning team. We all face so much challenges as well as the nurses and the doctors. Our work became extra challenging during this time, but we stepped up. We also know people from the outside, from the nursing home, stepped up too, like our daycare workers, keeping the buildings clean, the security officers, the truck drivers, the grocery stores workers. There are all a lot of people across the state who kept running. They all worked hard, and they made it possible for our nursing homes keep working. Nursing homes workers like me to do our jobs. We worked hard. We worked with our patients together through this pandemic. We need all of our essential workers. It doesn't matter where they worked and what their team is. We all belong on one thing. We all work together, and we all are there for our residents. Thank you.
Thank you so much, Ms. Snyder, and thank you for showing up to work every day during the last 18 months. You all do work together for these residents. We do have Sabrina Collins. Sabrina, I see you're on there. Just have to, I saw you for a second, Sabrina. Calling Sabrina Collins. I know maybe she ran off with a patient or a resident. Sabrina's a nursing assistant. She's on via Zoom, and she needed to testify between 1:15 and 1:20. It must be her break. Members, any discussion while we wait for Sabrina? Well, that was great testimony, and thank you, Ms. Thurlow, for your, the details on the numbers. That's what I was kind of looking for. 96 million would cover everybody, all, what do I add that up to? 79,000 employees in both assisted living and nursing homes at $1,500. It's a goal. It's a goal. Thank you. Representative Winkler, Do you have anything you want to add while we wait for Sabrina? Maybe what your plans are for next week, where you want to go?
I did have a question, maybe
Yes.
for Ms. Thurlow. I'll wait till you get up there to throw it at you. I am about as far as the legislature has from a health and human services expert. So I just have a couple of baseline questions I'm hoping you can help me with. Number one, I don't really remember the details of funds that were made available for long-term care. And I will ask the same thing about hospitals. I know that we appropriated a bunch of money last spring. I know that we did it for emergency relief under Chapter 12. I don't know how that was allocated to your organizations or what kind of access you had and whether that was used for temporary bonuses or premium pay of some kind. And then the second question is there a longer-term strategy in place to try to raise wages and benefits so that people are more likely to want to stay in your industry?
Ms. Thurlow.
So Madam Chair, Representative Winkler, if you don't mind, I'll take the second question first. We would love to engage in the long-term discussion on how to better raise wages and benefits for staff. I think it's fair to say that our reimbursement system that is in existence, largely dependent on Medicaid, is not super speedy to respond to the rapid upward growth of wages in our current environment. So I think that that's a discussion topic that we would welcome to have. But note it, recognizing that it is extremely constrained right now by the current constraints on the reimbursement system. As to the question about the funds that providers have received during throughout the pandemic, I'll give you kind of an overview, and with an invitation that we have two financial experts within the long-term care imperative that can go as detailed as you would like. But I would first say that money available through Chapter 12A10 has been of limited use to providers within during the pandemic. Although we held out great hope that 12A10 would be available for expenses such as hazard pay and the like, that has turned out to be a much more complicated situation than we ever anticipated due to interactions with federal funds that have also been made due to COVID response. There has been some funds available to long-term care through grants, through the CARES Act money, but I think that that has been the primary source to long-term care. And I think it's fair to say that, unlike other sectors, there was an assumption that 12A10 was going to be more helpful than it was. I will acknowledge that there has been federal money provided, especially to nursing homes, and that funding has largely been used to cover the increased costs of PPE and testing and other expenses. So there's been little use of that money for funds such as hero pay, bonus pay, hero pay, the like. But that's a brief overview, and I'm certainly happy to take more detailed questions, Representative. I'm at my heart a generalist, so I may need to phone a friend eventually if we need to go much more detailed than that.
Thank you, Ms. Thurlow. I saw Ms. Collins on here briefly, and then she went away again. Representative Winkler.
Madam Chair, I just want to make sure that Ms. Collins has a chance to testify before 1:30 if we can
I
get her
know.
back on.
Ms. Collins, I held up a little sign here, too, that said, Sabrina, you're next. We'll wait. She'll come back. You should probably stay, Ms. Thurlow.
Certainly, Madam Chair.
I didn't want to interrupt you when she came back on. Oh, they're trying to contact her offline. You could tell she was busy at work. She was doing her job. All hands on deck. I can't even imagine for those that had to test, and those of you that came down today too, taking time off to be here. Thank you, because I know you are spread very thin. Senator Murphy.
Thank you, Madam Chair, and I'm getting a message that Sabrina is there but has a bad connection. So I think our patience is warranted. Appreciate
Yeah,
that.
thank you.
And Madam Chair, I could ask Ms. Thurlow one question while we're waiting.
Senator Murphy and Kari, if I interrupt you, don't be offended, okay?
Okay.
Go ahead, Senator Murphy.
Thank you, Madam Chair, and it's good to see you, Ms. Thurlow. I appreciate you talking a little bit about both the experience of 12A, about the federal grant money, and of course, I think it would be right for us to spend a little more time, though this panel is not going to be the solver of the long-term care workforce issues going forward. I think it's important to segregate that and recognize that. I would love it if you could spend a little more time, to the extent you can, talking about the grants that did come and how they were used and what that means going forward in terms of supplies like PPE and testing.
Ms. Thurlow.
Madam Chair, Senator, I won't be able to provide a full accounting, so to the best of my recollection. Early in the pandemic, when CARES Act money was first made available, there was a certain portion of that money that was designated to MDH grants. And a certain portion of that money, the vast majority of the money that came to long-term care, it was for healthcare providers, generally speaking. But of the long-term care community, the vast majority of it went to assisted living settings for COVID preparations, PPE, other sorts of supplies that you may have to have on hand and the like. The rationale for that was essentially, again, this feels like so long ago, but the rationale for that was that 12A10 would step in and cover those costs. Again, without getting, this would be a long conversation in and of itself, but because of interactions and guidance between the federal government and my understanding of conversations with the state, 12A10 money has not been able to be used in that same way because there has been federal money provided through provider relief funds at the federal level that have allowed for some of that, but has not been utilized to make providers whole in those situations. There are still uncompensated costs and lost revenue because of low census and increasing costs as well. So to the best of my knowledge, and again, I want to provide those caveats because in no way do I want to somehow just forget to mention something. To the best of my knowledge, that has been the bulk of the appropriations to the community as of this date.
Thank you, Ms. Thurlow. Senator Murphy.
Thank you, Madam Chair, and thank you, Ms. Thurlow. And I appreciate very much the caveats, and I know it's been a long time. And I would ask, and we can follow up, but I would love to dig into that further with you and your experts
We
as
would be
we're
happy
working through this together. Thank you.
We would be happy to do that. Thank you.
Thank you. Members, any other questions? Topics, discussion? While we wait for Sabrina, she's still there.
Do you want me to stay?
You can go. You're excused, Ms. Thurlow. Members, any discussion on our topic today on long-term care, since it is in the language that came to us that long-term care needs to be covered? We just have to figure out how much and to whom and how that looks. So that, I guess we, Representative Winkler, will do that in the meetings going forward, you think? Instead of me throwing out my proposal right now?
Well, yeah, Madam Chair, it looked like Senator Kiffmeyer was seeking recognition, but I will just say that, of course, long-term care is an essential and necessary part of the work that we're doing here. I mean, just what we've heard in the first hearing and today, you know, the level of sacrifice and trauma that people experienced in making sure that vulnerable people were cared for is off the charts, and so we have to make sure we're doing that. And of course, we do need to understand, you know, where premium pay has been paid out in the past and how we can best make our money go as far as we can. And my anticipation for Thursday is that we will start to hear some more data from agencies about kind of the whole picture of how many people we're talking about potentially and maybe some preliminary conversation about how we could administer a program. You know, I would hate for us to have $250 million set aside and then have only voluntary employers who want to apply, provide that, when so many other workers have stepped up and not been able to do that. So I think diving into the numbers and figuring out that part is one thing. Understanding what we can do administratively is going to be really important too.
Okay, good, thank you. Senator Kiffmeyer.
Thank you, Madam Chair. I think very instructive, both last hearing and also today, hearing from those presenting, and our sympathies in their situations like that, especially proud of that. I worked my way through nursing school by working at a nursing home, and so I understand how attached they become to the residents there. One of the things that I think of, we had a great presentation today in regards to some dollars, some numbers, and some money. I think that really, really helps. I would like to see that from hospitals as well, to hear from them. I think that's going to be instructive as well, and I don't know if they're in the process of doing that, but I think it would be very helpful to have that, to do that. And I think it makes a difference when you have the total of 250. If we're looking at what we've heard today from nursing homes, I think we need to have that. I was also looking at the rules, thank you to Mr. Arneson, who got a copy of it to me with a little more data. I think one of the things for us as a work group is they define, what's a frontline work group? What is that? So we're focusing on the resources for that. And I was struck by some of the language and also some of the other states as well. One of them was the heightened risk to workers who must be physically present at a job site, and for many of whom, basically it's just saying that they had to be on site and physically present. There was no other way to do this job than to be present. And that posed for them a risk that was also, and the other thing I think they used here was for a longer period of time. Wasn't just in and out, it was for a period of time, a longer period of time. And I thought those were kind of two things that I thought were really important for us, and not just about who qualifies. I think we can figure that out once we go. But then the administrative and all the stuff that Representative Winkler has said are certainly practical solutions that I think maybe commissioners that are on this work group can help us, or Ms. Thurlow could help us again with, like, how do you do that? Same thing with hospitals. They know their base better than anybody. So what are their thoughts as far as those recommendations? But I think the bigger policy question for us is, what is that heightened risk, and what is that sustained in-person contact? What are those groups of people who had that in a very close and personal kind of a way, such as personal caregiving? There are also, I think, PCAs who went into people's homes. They were personal, they were present, there was a length of time, but if neither they nor the client had COVID, the question is, how does that fit in to the criteria that we see with nursing homes and then with hospitals as well? I think that kind of policy discussion of defining that, because there are many that I've heard from did incredible work. And so as far as we can go with this, again, recognizing that sometimes it may not, I was going to ask Ms. Thurlow before, what is meaningful? Is it 10,000 apiece? Is it 2,000 apiece? I mean, what is meaningful? I don't know if we're going to be able to always meet the criteria of as meaningful as we would like it to be, especially when you're trying to reach more people. And as soon as you start reaching more people, by its very nature, that individual check is likely to be less. And I think there's full-time consideration, part-time consideration to deal with, and all of that. Those are the kinds of thoughts that I have. I don't know how we, as a work group, come to some of that criteria, except for this is language right out of the federal rule. And we could adopt such language, or at least have it be a criteria that we start from. And I'd be glad to open to any other discussion, but I really thought as we start to talk about who and who qualifies or some, we need to have some sort of benchmark or definition of that to work with.
Thank you, Senator Kiffmeyer, and I know we have talked about that. And I don't know at what point, Representative Winkler, you want to do that, put those parameters so we can narrow in quicker. I agree with you, and I think maybe Ms. Thurlow was saying maybe the $1,500 would be meaningful, since that's what they would make if they were off for 2 weeks. And like you said, we don't know if we can go that far because there's a lot of other people in the hospitals. Are you, Representative Winkler, when you're having do you know which agencies you're having next week, or should we put the hospitals on alert for next week sometime?
Madam Chair, so this Thursday, we will hear from DEED with some an overview on kind of employment sectors and numbers, and obviously Commissioner Grove can give us a little heads up. And, you know, you and I have talked about trying to meet a couple of times per week. I know Commissioner Robertson has suggested that, Tuesdays and Thursdays at noon. I also know that some members of the working group have to travel in order to be here, and so some consideration for not having many short meetings but fewer longer meetings is also something we have to try to work out. But once or twice per week, and so I think next week we should start looking at some of the particular sectors. You know, hospitals, we've heard from meat packers, we've heard from grocery store workers. There are a whole range of other employees that could qualify. But I think the most useful next step for me is to hear kind of numbers overview from DEED over these sectors and how many employees are in there, to make sure that we are covering the whole range of what we could consider before we start trying to narrow anything down. I will also say that $15 an hour times 80 hours, which is 2 weeks, it comes out at $1,200. So that's another, you know, way of looking at it as a median.
Thank you. That's good. Are you, Commissioner Grove, you're going to be ready for next week?
Yeah, thank you, Madam Chair, members. We will be. You know,
Thursday.
this Thursday, I believe. Yeah, we have a window of time available then. You know, we're going to take as our jumping off point the categories that House and Senate staff shared at our meeting last Tuesday, is just a kind of view of the world. And we'll be very clear about what our data tells us, what it doesn't. As you'll see, we can learn a lot from occupational data, and then there's a level of detail that is somewhat more obtainable through employers. So there's I think some data questions we'll have before us. We'll do our best to get the data in the categories that were defined by House and Senate staff last week.
Thank you. I have a conflict this Thursday, so I'm going to try and make it via Zoom, but I may have to be excused, so I want to just give you a heads up on that. And I'm thinking the next week, if that would be amenable to those on the committee, if we could just do the next Wednesday at noon and make it a little longer. Is that okay? Not this week, Mary.
I didn't hear which day next week.
Oh, Wednesday? Everybody look at your calendars. Would people like it earlier? I know Senator Kiffmeyer would like, because she has to drive over an hour to get here.
Madam Chair, on the road next week, Wednesday. It's going to be tough for me for Wednesday hearing.
Okay.
Maybe schedule offline, but just apply.
Same here for me, Madam Chair. I already have commitments with
On Wednesday?
non-changeable and already rescheduled.
All right, we'll go back to,
Madam Chair, my suggestion would be that we plan for Tuesdays and Thursdays noon
Okay.
to 2, and if we decide to extend one of those,
okay.
then at least, and then maybe cancel the other or something like that, but at least as a kind of a guideline that's the starting point. I think it's otherwise impossible for us to start to
Yeah.
manage everybody's schedule.
Madam Chair, that's what I did. I put a hold on
Tuesday,
Tuesdays
Thursdays.
and
at noon?
Thursdays, and so I push things into Monday and Wednesday. But I think the other thing, though, is thinking of Minnesota, though, our days are precious. We don't have a lot of summer. And I also think of the staff and the other folks in the room as well, whether we would consider something like an 8 a.m. to 12, a time slot, but in the morning, maybe, to consider the possibility of having that, and then the rest of the day, we actually have a little bit of a chance to enjoy Minnesota. It's one thing for us, we're here, I'm committed to do whatever it takes, but when I look around the room and see others, just a thought, if it might work, that would be a possible opportunity as well.
Go ahead.
Yeah, Madam Chair, Senator
Representative
Kipmeyer, I think, we can try to find a way to do that going ahead. Make some accommodation to doing it starting in the morning, but I think to start, we'll do this noon to 2, and then we'll at least give some notice if we're going to make a change like that.
Thank you. We do have one of the testifiers who couldn't make it earlier, if you guys don't mind hanging around. We have Amanda Gruber from Pathways, or from 3 Links, and she's on via Zoom. And Amanda, if you could take, yes, you took your, there, she's waving. Welcome
Yes,
to the.
I apologize. I had 2 Zoom numbers, so I used the incorrect one. I apologize.
Absolutely okay. Just state your name for the tape, and welcome to the committee.
Thank you so much. My name is Amanda Gruber. I'm a household coordinator at 3 Links Care Center in Northfield here. And then I just wanted to say I started my journey in healthcare by watching my mother. She was a nurse for 52 years. She cared for the residents of the nursing home she worked at. And soon her passion kind of got onto me. And so then I started volunteering after school and working as a nursing assistant. And I've been one since 1995. I'm one of the million direct care workers, which include maintenance, housekeeping, activities, dietary, and of course nursing, who come to work every day, not because of the paycheck, but because they really do care. Even before the pandemic, caregivers worked tirelessly balancing short staffing, new regulations, frustrated residents, family members, and lack of supplies. And with low wages, staff may not be able to have enough food to feed their families or gas to get back and forth or money to pay the rent and utilities, but they never let their own struggles impact the care that they give their residents. Caregivers always individualize, personalized care and offer opportunities for residents to feel purposeful, included, and important, and they know how their morning routine goes, how to calm them when they feel lost and confused and don't remember who they are. They comfort them when they are sad, hold them when they are scared, and laugh with them throughout the days. And our residents become our family and are the best part of our job. With the pandemic, we still had all of these other challenges, but new ones arose. We really had to start homeschooling our children. We had to really isolate from our friends and our family to protect those residents in our community. We lost family and friends. I lost my father during COVID as well, at the same facility I was working at as well. We were dropping off groceries for those who couldn't get out, coming up with innovative ways to connect residents and families, and really putting others' needs before our own, kind of not even thinking about self-care, just really about survival mode. The heroes we already had in place, they stepped up once again, meeting every challenges with that can-do attitude. Everybody was hands on deck. Initially, communities did come out in droves, helping us, sewing masks, offering food recognition. And for the first time, we really felt, empowered during those few short months that kind of happened. But then it kind of quickly fizzled out, and community members' compassion kind of dissipated, and demands and blames increased, and once again, kind of forgotten about again. And many caregivers that I've come up against have become fatigued emotionally, physically, working doubles, picking up all of the slack, doing multiple jobs, trying to make sure that everything is still going. And due to that overwhelming expectation from all areas, family, life, work, without that proper acknowledgement or compensation, people kind of got burnt out and fled the industry. And then we still have all of our people who are still working really hard. As that Delta variant rises, we are again thrust into that hero mode. But with so many people who have left our industry, we do worry who will care for our seniors. There's only so many of us left. Hero pay, I feel, is really a way to feel valued, appreciated, to help us provide self-care for ourselves. And it will also be a way to recognize the struggle these heroes have endured even before the pandemic, and hopefully entice new heroes to join us and keep our current heroes as well. So that's just kind of what I wanted to say. I apologize for getting emotional, but it's been just a tough journey, and I just want to be a good representation for all the people that haven't had a chance to speak.
Thank you so much, Amanda, and thank you for what you've done over the last 18 months and for being another hero in the long-term care industry. Thank you.
Thank you so much for listening.
You're welcome. And Sabrina's still there. She's out there. If you can hear us, Sabrina.
Madam Chair, I don't think she's going to be able to join us today.
Thank you, Senator Murphy. Yeah, Representative Frazier.
Thank you, Madam Chair. I just wanted to say, and it kind of echoes what what Amanda spoke to about recruiting and retaining for our future employees in this area. I think it's very good, and I'm actually pleased that we're having this conversation because some of the larger long-term care facilities are in my district. They're literally blocks away from my home. My wife and I, during the pandemic, when the only thing we could do was get out and take a walk past North Ridge every single day. And then St. Therese is also in my district. So I'm always happy to have this conversation, but in particularly to have this conversation because what I heard throughout the testimony was the thread throughout the testimony was that this is an issue that has been ongoing prior to this pandemic. And Ms. Thurlow, thank you for mentioning that you want to engage in the conversation around how we can do better in the future with wages and benefits and recruit and retain folks. I'd like to take you up on that conversation. I'd also like to know, since this conversation has been ongoing or since this issue has been ongoing for a while, if there's any prior ideas or proposals that you had out there, I'd like to take a look at those because now I think with the light that we put on this now because of the pandemic, maybe we can revisit those things and they may make a lot of sense now that we can try to implement those. So any past proposals I'd like to take a look at as well. And also try to be creative and think about what we can do moving forward. I just have to note that many of these workers, their spouses may have also been essential workers, which means someone had to care for the kids. And the reason I make that point is because we heard testimony in the last meeting where we had some of our educational assistants that said their job title switched. They became care providers. They were in the schools caring for those kids of essential workers to make sure that they could get to work every day. And I just don't want to lose that point that many of these essential workers were day in and day out with individuals that could have exposed them to the virus. Still doing it now, but I want to make sure that we continue to center around that. It's going to be hard for us to make a decision on how we decide who's going to get what and how much they're going to get. But I think we have to make sure that we continue to center the fact that many of these essential workers were in similar situations, regardless of what field or industry that they were in. We're going to get some of that data from DEED to look at those industries and look at the impacts and where outbreaks were. So we'll have more data. But I also like to say, just for those that weren't aware, House File 41, which was the essential workers bill, it did have some criteria as to how we could decide who got the resources. And I want to thank Senator Murphy for carrying it on the Senate side. I know it didn't go far, but it was there, and it does have some criteria, so we may not have to reinvent the wheel as much because we did some work on the front end during the last prior legislative session. Thank you, Chair.
Thank you, Representative Frazier. I was disappointed this year when the House didn't have a long-term care and aging committee, so I suggest you should chair that on the House side and talk to the Speaker because I would love to work with you on these issues. So yeah, we could really use an advocate in the House, so thank you very much. That's helpful.
Madam Chair, we did have 4 healthcare committees for the record.
But not one on long-term.
Is 4 enough or is 5 too many?
Never enough. Thank you. Any other questions or comments, members? So, do you want to talk about your next meeting? You already did, but you're good?
Madam Chair, we'll see you on Thursday.
We'll see you on Thursday at noon. This meeting is adjourned. Thanks.
Recording stopped.